Hello and welcome to our Global Health Case Competition presentation. It is our honor to present to you our plan we created to address institutional racism and its effects on Roma health in Poland. I would like to take time to introduce our team. My name is Sydney Evans and I am a first-year Master of Public Health student in Community and Behavioral Health. Josh Bentling is a first-year Master of Public Health student in Occupational and Environmental Health. Abia Lavarson is a first-year Master of Public Health student in Community and Behavioral Health. Radhavela Murray is a first-year Master of Public Health student in Epidemiology and a third-year Biomedical Sciences major in the undergrad to grad program. And Eliza Steer is a first-year Master of Public Health student in Community and Behavioral Health and a fourth-year Public Health major in the undergrad to grad program.
The primary aim of our intervention is to positively impact the health outcomes of Roma people by addressing systematic issues and the social determinants of health that this population faces. We want to focus our efforts on factors within the walls of the hospital and outside in the community to truly cater to and understand the Roma people. To do so, we will focus on respectfully reaching out to the Roma people, assessing the effectiveness of current conditions both internally at the hospital and within the community, adopting and implementing the necessary interventions based on relevance, need, and economic feasibility, and evaluating the potential success of our efforts while ensuring their continued maintenance.
For our interventions, we have produced a logic model and simplified it into a conceptual framework. Our interventions will need an input of funding and materials. This will lead to having an advisory board developed, interventions developed, and the readiness completed. Our short-term goals for this are to have a program exist. Our medium-term goals are to reduce discrimination against Roma and to improve advocacy. Our long-term goals are to improve health outcomes for Roma and make them feel more included in healthcare.
Now we are going to do a historical overview of the Roma people and Poland. The Roma people are an ethnic minority that started out in Europe but have migrated all over the world. Historically, the Roma have experienced a great deal of segregation and racism. Recently, there has been an increase in violence and hate crimes against the Roma, leading to a concern for their overall well-being and safety. Poland is one of 5 countries in the European Union that is not fully committed to the 2008 European Union anti-racism law. This is something that we as healthcare administrators should be concerned about because it means the country of Poland does not place an emphasis on the health outcomes of Roma people. In addition, Poland only condemns crimes against Poles, not all individuals. In the past 4 years, Poland has experienced the highest record of anti-Gypsist incidents. Thus, we as hospital administrators should work to do our part to be ethically and emotionally considerate of Roma to improve health outcomes for Roma in Krakow. While we are just one hospital in Krakow, the change starts with us. We as hospital administrators need to encourage Roma to use our healthcare facilities. The interventions we discussed today are proposed with the consideration that we are just one hospital and that the change we can hope for is fairly local. We do discuss some long-term, larger-scale goals towards the end, but the interventions proposed today are some of the stepping stones towards a more inclusive healthcare setting overall.
Now that we have touched base on Roma and Polish history and how we fit in, here's our proposed intervention timeline. We feel that in order for our implementation toolkit to be effective, we must have baseline data, which can be collected through a readiness assessment program. In order to have a clear understanding of the situation and issues at hand, we must implement a readiness assessment program that addresses people's thoughts and behaviors externally and internally to the hospital setting. Additionally, both quantitative and qualitative research methods will be implemented to capture a more holistic picture. The baseline data collected through the Readiness Assessment Program will serve as evaluation points later on. Baseline quantitative data that would be available to the hospital would revolve around access of services, for example, number of ER visits Roma people make in a year and number of prenatal appointments Roma women attended over the course of a year. This data could be collected through electronic health records of Roma patients. Surveys are another method of collecting quantitative data, and in this case, it would be ideal to collect hospital personnel's attitudes and perceptions of treating Roma patients through questions structured as, how well do you agree with this statement, and giving them options to choose from 1 through 5, for example. This information would be key to addressing internal bias and diversity training, an intervention that will be discussed later on in this presentation. Here are our qualitative data collection methods. Hired personnel would interview Roma community members and would aim to capture perceptions of accessing healthcare, as well as facilitators and barriers to accessing healthcare. For the Photovoice Initiative, Roma people would be able to convey their experiences to us healthcare administrators through their own lens, rather than us prompting them with questions. Lastly, focus groups with key members of the Roma community would give us a better understanding of where the gaps in the system may lie.
Josh briefly mentioned the Photovoice Initiative in the description of qualitative data collection, and it is a truly valuable initiative as it provides the first-person perspective of the community we're trying to serve. Photovoice is an anthropological technique acclaimed for its emphasis on community participation and relatively simple methodology. Essentially, during the readiness assessment, the personnel hired to interview would undergo ethics training and hand out disposable cameras to Roma community members. The participating community members would then document their experience with healthcare, including transportation, living conditions, the healthcare setting itself, and post-hospital lifestyle, and then return the film to our hired personnel. The resulting images can then aid in qualitative assessment from the perspective of the Roma community members. Furthermore, the images can be used in the Welcoming Environment Initiative by enabling creation of a journey map that we will later discuss.
After our initial evaluation, we came up with 3 interventions that will be addressed in our implementation toolkit. In this section, we will be discussing a plan for internal diversity training, ambassador training, and a welcoming environment initiative. We chose to include an internal bias and diversity training in our implementation to combat systemic racism seen towards the Roma people throughout Poland. Specifically looking at the healthcare administration in Poland, we noticed a lack of current practices for diversity and bias trainings for the entirety of healthcare staff. In healthcare systems that had diversity training, it was only for nurses. Despite individuals in positions of power and authority knowing about the systemic racism occurring towards the Roma, there has not been a conscious effort towards reducing that burden. In the Roma community, we identified long-term hardships including poor housing, poverty, and lack of access to consistent medical care where they felt safe and respected. Thus, we feel it is important for our hospital staff to have a paid but voluntary training opportunity for internal bias and diversity. Our proposed diversity and bias training will take place over 10 weeks, with training being 1 hour a week. All hospital staff, not just nurses, will be encouraged to attend and paid for their time. This process will be repeated every 10 weeks. We included these impactful quotes from multiple survey groups regarding pregnant Roma and access to healthcare. We feel these quotes provide an insight to the reality for many Roma across the world, but also in Poland. A pregnant woman stated, "When I was in the delivery room, the doctor started to call me names, gypsies, and hit me really hard on my face. The nurse who was attending me hit me on the legs. It hurt. It gave me bruises."
Thank you, Eliza. Now we will move on to the ambassador program.
The ambassadors and the ambassador program will be mediators hired by us, facilitating as like a bridge between the hospital environment and the Roma community. They would attend healthcare visits with the Roma, and they would help familiarize Roma with how to navigate healthcare and their right to health. They would also serve as buffers for discrimination from healthcare providers, and they would advocate for Roma people. This program would help increase awareness for hospital services and help Roma gain access to the healthcare system.
Final intervention in our toolkit is the Welcoming Environment Initiative. The basis behind this intervention is promoting inclusivity and patient satisfaction by showing members of the Roma community that we respect their heritage. People typically come to the healthcare setting under less favorable pretenses and are often faced with difficult decisions and rules and regulations. Although these processes are essential for our hospital to function, a way we can alleviate some of the stress is invoking a sense of familiarity and respect within the design of the hospital's visual environment. Through donations and commissions, we can display pieces of Roma heritage, including artwork, dresses, jewelry, and more. This would essentially be a cultural showcase and can even be a stepping stone for our work as a hospital for increasing diversity. It could be the pioneer initiative for inclusion of artwork from other cultures within our community. Additionally, we would request the aid of Roma art professionals to ensure respectful and proper installation of these display pieces. As previously discussed, we aim to include ethically permissible images from the Photovoice qualitative data collection. The photos taken during the readiness assessment are representative of the Roma people and what they face, and we can use them to make a community-based journey map for display. Additionally, some of the art pieces you have seen in this presentation were created by Gabby Jimenez, Delaine Labas, and Damien Labas. These individuals are or were proud Roma artists and social justice practitioners, and our team believes incorporation of their artwork would be valuable in creation of the welcoming environment. Again, these 3 proposed interventions will be the primary efforts for internal change and community engagement. The order of interventions by which we will prioritize our efforts will be based on the readiness assessment.
Thank you, Radha. We are now in the final stage of our intervention, the evaluation. We chose to take both an outcome and an impact approach to evaluating our intervention. An outcome evaluation measures program effects in the target population by assessing the progress in the outcomes of that the program is to address. A question that may be used in our outcome evaluation may include Roma patients who received a specific intervention component were more likely to seek healthcare more regularly, appropriately, and comfortably. An impact evaluation assesses program effectiveness and in achieving its ultimate goals. This evaluation shows the degree to which the program meets the goal of positively impacting the health outcomes of Roma people by addressing systemic and social determinants of health. For example, how much the Welcoming Environment Initiative increased Roma utilization of healthcare services and facilities beyond the duration of this intervention program. We wanted to emphasize that the tracking of our health data will be done by way of the readiness assessment, specifically through electronic health records, qualitative and quantitative interviews, and surveys. We will be conducting evaluations every 6 months for the 3-year duration of our intervention.
Thank you, Sydney. Now we will talk about long-term consideration. The hospital administrators can join and develop advisory boards to help promote health issues affecting Roma people. This is especially needed when changing laws surrounding requirements for obtaining health insurance. We would interact with key government officials so they can understand how laws affect Roma health and potentially change them. We would also create an advisory board between Roma and the hospital so that Roma can actively participate in their healthcare decisions, making sure they receive care and they can experience less discrimination.
In the next section, the budget and time frame of the project will be presented so that the logistics of our proposals can be better understood. Here is our proposed budget breakdown. As you can see, the greatest cost to implement our interventions would be from personnel. There would need to be some hires made, time spent training, going through the data, conducting interviews, and more. The next biggest section of our budget is technology. We need cameras for the Photovoice, virtual conferences and meetings to be set up, and to possibly change the healthcare data systems, for example. Materials would also make up a decent percentage of our total budget, as we would need to purchase the artwork for our welcoming environment, provide handouts at training, and any promotional material we may want to develop. Evaluation of these interventions requires special budget considerations so that there is sufficient time and resources available to analyze our interventions. Moving on to the timeline, it is structured in somewhat of a Gantt chart way, so that one can see there is work being done on multiple fronts at multiple points in time. This chart would allow us to stay on track for the indefinite future. The goal is to evaluate every 6 months for 3 years, always comparing back to the baseline data. However, the long-term goal is to make these processes routine and a part of the normal functioning of the hospital.
Thank you, Josh. With that, we have concluded the presentation of our intervention components. Keeping our goal of positively impacting the health outcomes of Roma people by addressing systemic and social determinants of health in mind, we thank you for your time, consideration, and for your commitment in addressing and improving the health outcomes of Roma people.